Hello, everyone. I'm Marcia Mott, and welcome to UF Health Wellness University webinar. Thank you for joining us today as we discuss fertility preservation. I'd like to introduce you to our speaker, Dr. Alice Rhoton-Vlasak. Dr. Rhoton-Vlasak is an associate professor at the University of Florida Department of Obstetrics and Gynecology, working in the Division of Reproductive Endocrinology and Infertility. If you have questions for our speaker today, you can submit written questions at any time using the Q&A button at the bottom of your screen. At the end of this presentation, I'll read your questions anonymously. We will only be accepting written questions today, and we're going to do our best to get through as many of them as we can. Dr. Rhoton-Vlasak, I'm going to turn it over to you now. Oh, you got to turn your...
Thank you very much for having me today. And I appreciate everyone that took the time out of their schedule today to be part of this lecture series. What I hope today is that you'll learn something new that you haven't heard about before. And hopefully, if you're in a situation where fertility impairment could affect someone such as a friend or family member, you'll know where the right place is to turn to get help. And so I actually have been at the university 22 years now, plus my training there, and am the director of the UF Health Hope Network, which stands for Helping Oncofertility Patients or Oncology Patients Become Educated about their options for fertility preservation. And so the first slide is really to show you that it takes a whole team to run this program. And so I'm involved, and then there's numerous other physicians, nurses, psychologists, oncologists, even foundations that are local, such as the Climb for Cancer Foundation, have been huge supporters of this program, and I'm really thankful for them. Ron and Diane Farb, who have basically supported just about every initiative this program has undertaken. And so I also just want to mention that it is Earth Day, so hopefully you were able to do something to celebrate the earth and community we live in. We're really fortunate here to have a beautiful city filled with trees and green spaces. And I know I'm really thankful for that. And so the first thing about this field, if you've never heard of it, is to distinguish fertility preservation from oncofertility. And so fertility preservation means that we're considering preserving reproductive abilities due to some type of treatment. It could be medicine, it could be surgery, it could be a disease itself that alters fertility, usually for benign reasons or for other social reasons. So there are many women now that have careers who are coming to freeze eggs just because they're getting older and they want to preserve their fertility. The other part of this is oncofertility, which means that someone has been diagnosed with a cancer or malignant disease, and that the treatments, including radiation or surgery or chemotherapy, could impact their long-term fertility. And so they're doing things to preserve their reproductive abilities. And so when you think about what are we talking about, what could need to be preserved, well, it mainly is just about anything that has to do with getting pregnant. And so that means things like sperm, you need to have eggs, you could have a surgery for cancer that involves removing part of the vagina, you need a vagina. You need to have fallopian tubes that are open. That's where the sperm and the egg meet. You need to have a normal uterus, which is where a baby would grow. And then you need to have normal hormones cycling to allow for ovulation. And then, I mean, the other thing is you have to feel good enough or well enough to have intercourse to be able to get pregnant. So as I go through the options for fertility preservation or oncofertility, it's thinking about preserving these things. And so it actually is a beautiful field that we work in. This is a picture of Lake Alice at sunrise. I run around there many mornings. And so what we're trying to do is, just like the hope of a new sunrise, leave these patients with serious diseases with hope for family building and reproductive options in the future. And so, you know, so what am I doing here? Why are you here on this call listening? And so again, it's to make you aware, so you think of this for potentially yourselves, your friends or families, and mention it. They will thank you later. And it's really about protecting sperm, eggs, the ovaries, the uterus, and the hormones that help people be reproductively capable. And so, you know, it's sort of interesting that I was, you know, so I asked the question, why am I here? So part of it is really, you know, to tell you about this field. The other why is that, you know, fortunately for me, my family moved to Gainesville in 1972. And I was at that time in 4th grade. And I feel like it turned out to be a great thing for me. I grew up here, I went to school here, went to med school here, went to residency here, got a job here. I'm at my mother's house tonight, not somewhere else, because my mom was in UF Health Hospital last week. And so I'm helping her out this week. But the history of the place is that, you know, it was named Shands Hospital in 1965. I was very good friends with Dr. Cade, and his children were in my church classes. So Gatorade was invented here, and many historical things happened along the way. And I feel lucky that I was part of that history. And so, you know, this is when my father had arrived in Gainesville. It was a very small college of medicine. And thankfully, you know, he came and we all came along with him. And so, you know, basically because of efforts that occurred back in the 1960s, a medical school was started. And, you know, I was able to benefit from that. So that's how I ended up here on the other side of that question, besides how did I end up here giving this talk tonight? And so a typical case that we might see in our practice who might need these services is, for example, a 28-year-old woman comes in with newly diagnosed breast cancer. She's married and wants to have children. And as she contemplates what's going to be done for her breast cancer, she is thinking, will she be able to have the family that she hoped for? And so she's worried, and appropriately so, that the medicines or radiation might cause her to be infertile or sterile. So hopefully at the end of this, you'll know what can she do. And if you look over here, you can see these bars represent different cancers in reproductive age groups. And so there are quite a few cancers that can affect individuals under 40, and those are the population that we're thinking about. Another very common case or situation would be an 18-year-old male is diagnosed with testicular cancer, and he wants to have children in the future. He's planning to get surgery and possible chemotherapy. So what could he do to preserve his future fertility? And so I think one of the most important parts about what we do is, you know, in these difficult situations where somebody has just found out about a serious disease, we have to see them to talk about something they didn't even think about before today. And so it's a very careful conversation, you know, considering the whole person, considering their future, in order to, you know, have a compassionate conversation about fertility. And some people are quite interested and really want to hear about it. Other people don't care so much. But there is good medical data that if they have an option to make a choice, they have better long-term well-being and survival. And so there are actually professional guidelines from the cancer societies and the fertility societies recommending offering patients the option of banking sperm, eggs, or embryos, or even ovarian tissue as ways to protect fertility from different fertility altering therapies. And so some of the other things that people can experience as a result of especially cancer therapies are if they lose all their reproductive hormones at a young age, that means they lose fertility and they become at a loss for their reproductive hormones. They can start to lose bone. They can have changes sometimes in their cognitive abilities. They often have problems related to sexual relations, early heart disease. And so I do believe that we have an ethical obligation to present these issues to patients as part of informed consent and to improve their survivorship and long-term care. So there's other things that can be impacted besides just fertility. And so what is it about especially oncofertility patients that alters reproduction? And so there's really a number of things that surround this patient, and that includes chemotherapy. Many chemotherapy drugs are directly toxic to eggs or sperm, especially in high doses. For women, age also makes a huge difference. So even if a female didn't get any fertility altering therapy, just age being older impacts fertility. So the older a woman is when they get these fertility altering therapies, the more impact it has on reproduction. If you get radiation therapy, it can affect the eggs and sperm as well as causing some damage to the uterus. And then if you lose your hormones or parts of your reproductive system are removed, that can affect fertility. And sometimes even just being sick from a serious disease or cancer can reduce sperm counts and make especially men less fertile. And so for women, it's just important to realize that we're born with a finite number of eggs and that this peaks when we're inside our mothers growing at 6 to 7 million. And then by the time females are born, they've lost 80% of their oocytes already. And then during their reproductive life, about 500 total will ovulate until eventually you run out of eggs that are functional and you're in menopause. So these changes can be more dramatic early on for females than males. And so, you know, you may not know these diseases, but there are a number of non-cancer diseases that can have treatments that affect fertility and might be people that we offer fertility preservation to. So some more common things are things like sickle cell anemia, especially if they needed a bone marrow transplant. Sometimes galactosemia. Turner syndrome is a genetic condition where women are born with no or less eggs. And then nowadays, more and more transgender individuals are considering banking sperm or eggs before they transition. And some people are now freezing eggs for purely social reasons, meaning that they are not sure when they will meet someone to have children, and they want to preserve that potential. For cancer-related reasons, there's a variety of different cancer types, different leukemias, bone cancers, brain tumors, breast cancer. And depending on the type of cancer and the type of treatment, will help quantify what is the risk that they'll end up being without fertility or low fertility. And so these type of treatments like whole body radiation, chemotherapy for a bone marrow transplant are much higher risk for being infertile or sterile than treatments for these types of diseases. And so when we see patients, we talk about, well, what is risk based on your type of condition and your type of treatment to make a decision what they should do. And so at UF Health, we see probably about 10% of the oncology patients. And the reason it's low, there's probably numerous reasons, but one is that not every patient is getting a treatment that will affect their fertility. And then sometimes patients don't want to see us because they don't want to really talk about this. Sometimes somebody didn't think about it, but that's, something that is pretty uniform across cancer programs. So there's a variety of reasons. We see more males than females. It can be limited by time, cost, and access. The other problem is that insurance in general doesn't cover any of this, although for us, we're very fortunate because Gator Care, which is our internal health insurance, does cover this. And even for inpatients, we have a way to see patients in the hospital for these services. And so if you don't remember anything else about this, just remember that the goal of this is that every individual before treatment would have an opportunity to discuss this when they're going to be getting life-altering treatments or fertility-altering treatments. And so it's sort of interesting to think about how long have these type of technologies been available. And so in order to have a baby in the future from frozen sperm, this was first done in 1953. So, I mean, about almost 70 years ago. In 1978, so about, 43 years ago or so, the first baby was born through in vitro fertilization. The first baby that was ever born from a frozen embryo was in 1984, not that long ago. It was only about 7 years ago or so that egg freezing, not sperm, but egg freezing, became a proven method, and I'll tell you why in a minute. And then in 2020, we have also now been able to freeze ovarian tissue from women before treatments and then transplant it back to restore fertility and hormones to preserve fertility. And so for men, what they do is, we see them in clinic or in the hospital. They obtain a sperm sample through masturbation. We can freeze anywhere from 1 sperm to millions and millions of sperm. And then those sperm are frozen indefinitely until they come back to use their sperm if they need it with either intrauterine insemination or in vitro fertilization. It's a proven thing. It's fairly inexpensive as far as fertility preservation options go. So this is something we do quite frequently. For prepubertal males, there is no proven option for fertility preservation, but there are studies going on to be able to remove a piece of tissue from the testicle and then take out cells in the future and mature those into sperm, and then allow those to be used at some point to have children. This is still experimental, but probably in 10 years, this will be a mainstream option for prepubertal boys who aren't making mature sperm. If a man did nothing, or they didn't want to bank sperm and they ended up being, sterile in the future, it's very common for couples to use a donor sperm from a sperm bank. And it has a very good success rate, and it's very common, easy thing to do for individuals or couples who need this. For females, there's multiple options. So option one, if the female has a partner, they could go through the in vitro fertilization process where their ovaries are stimulated, then their eggs are retrieved out of the ovary with a minor surgery. They're mixed in a dish with their partner's sperm, and then you grow an embryo that would be frozen to come back and have a baby in the future. The main considerations are the cost, and it's about somewhere around $12,000, so more expensive. It takes about 2 to 3 weeks, so it can delay cancer therapy. And then if the patient is very ill from her disease or cancer, sometimes this isn't an option because they're not medically well enough to go through this type of treatment. The other option is to freeze an actual egg. And so the female would go through the identical ovarian stimulation. Her eggs would be removed, and this is an egg in a dish before freezing. It's the largest cell in the human body, which is kind of cool. And so for many years, eggs were unable to be frozen because when the eggs were being frozen by the old method, ice crystals would form in this water and damage the egg spindle that holds DNA. So when the eggs were thawed, they could not be fertilized. But a newer method has been developed. It's a rapid freezing where the liquid goes straight from liquid to solid. And these are what frozen vitrified eggs look like. And this is very successful. Then when the eggs are thawed, they get fertilized directly by injecting a sperm into the eggs, and you make an embryo that can then help them have a baby. And this again causes about a 2-week delay of whatever treatment, and it costs about $8,000, but it's highly effective and quite common. The next thing that's relatively new, but it's being done all over the world, is freezing ovarian tissue. So the woman's eggs are found in the cortex of the ovary. And so what happens is that you take out a piece or a whole ovary, and then you portion the cortex into little slices, and you freeze these slices. So then in the future, when they're ready to have children, they come back and you retransplant that tissue into the ovary area on the other side or the same side, and then it reactivates and they become fertile and they can have children. And so the way it looks is that, you take out an ovary. This is an ovary, what it looks like, when it's taken out. You take out all of it or a piece of it, and then you make it into tiny slices that are about 1 millimeter thick. And then you basically, have the slices from the surface in a dish, and there's a special device that you use to then freeze this tissue. And then it's transplanted back either under the surface of the ovary or on the surface. And basically their hormones start cycling again. they have periods, they're fertile, and they can try to get pregnant the natural way. And so, you know, the nice thing about this is that if their treatments caused them to become in menopause at a young age, this will reverse that and all those symptoms. The thing is, these pieces don't necessarily work forever. So if somebody wanted multiple children, they might have to get more than one piece transplanted over time. And the other possible option for fertility preservation is to give women a drug that actually turns their ovaries off and become very quiet with no dividing cells. And that may actually protect the ovaries from chemotherapy. This is experimental, but many women will choose this option actually because it's more inexpensive, it's less invasive, it takes less time, and it doesn't disrupt starting their other cancer treatments. The other option, if somebody was going to get pelvic radiation, is that the ovaries could be surgically moved either behind the uterus or out to the side of the pelvis, like out to the side, or up out of the pelvis so that they're not in the radiation field. And so some women do have a surgery to get their ovaries moved before pelvic radiation. And so after, I finished going through all this, you might wonder, well, so why don't we always do this? Well, so there's a variety of reasons why people don't always choose to do this. And so one thing is the cost. I mean, if insurance doesn't pay for this, then, trying to raise $8,000 for a procedure very quickly may be difficult or impossible. There are several charities that people can apply for funding to get help with this. And sometimes they do this. We also have some funding from the Climb for Cancer Foundation to help patients. Another reason is just the time. So sometimes people, found out Monday they have cancer, Tuesday they see us. If they do, especially a female, what we're offering, it could delay them starting chemotherapy by a week or two, and they don't want to take the time that it would take to do that. They want to get started with the treatment in this very fearful situation. Sometimes people are just afraid or don't, want to go through any of these type of procedures. So our job is to educate them and offer them options. But even then, some individuals don't want to do it. There is no evidence that if you freeze eggs or sperm, that it increases the risk of birth defects down the road. Another reason it might not get done is that no one mentioned it. And if nobody mentioned it, you won't even know it's an option. They also may not be going through treatments that impact fertility, so it isn't necessary. Some people aren't interested because they just aren't, or other people may plan to live child-free. And so whether their treatments impact their fertility or not, that isn't something they really want to hear more about. Some people may be too sick for it to be safe to go through, an ovarian stimulation and the surgery to remove an egg or ovaries. So they are not even candidates to do it. And other individuals say, thank you for providing this information, but we don't really want to do anything now. If individuals chose not to do anything, and they become sterile or infertile, in the future, they could use donor eggs or donor sperm or even a surrogate if their uterus was removed in order to be able to have children. So they do have options down the road, no matter what they choose to do. And so, we work basically out of, UF Health Reproductive Medicine at Spring Hill. We see patients actually 7 days a week. Like labor and delivery, people ovulate every day. So we're open every day, just like people having babies every day. Labor and delivery never closes, neither do we. We also have an inpatient nurse navigator that sees all inpatient oncology patients for fertility preservation. And, if you were trying to reach me, you had any questions, you knew someone that needed this or wanted to refer friends or family, this is the phone number to call. And, we also have, a program that we've received funding for from the Pruitt Foundation and for Climb for Cancer Foundation. The funding we've had has helped support research right now, primarily to get our ovarian tissue freezing program up and running. We have funds that have been given for patient care support, and we have funds that have been used actually for education of providers, and had our first meeting for healthcare providers that was funded entirely by the Climb for Cancer Foundation in 2019, and we're planning another meeting in 2021 so that all healthcare providers will be aware and utilize these services when they're needed. And I have a picture at the end of my father, who really was my inspiration. He was a neurosurgeon, and he was really interested in the pituitary and the hormones that come from there. I didn't choose to be a neurosurgeon, but I sort of fell in love with the pituitary gland, which is the hormone producing gland in the brain that helps people be able to reproduce normally. And so everything I do involves manipulation of those hormones to help people build their families. And so really, that's the end of what I have to say today. And I wonder if anyone has any questions or comments.
That was a great presentation. Thank you. Yeah, we've had a few questions that came in. Let me go ahead and go through some of them here. Let's see. Roughly how much does it cost for a healthy female to preserve her eggs, even if it was just due to an age-related issue, not necessarily a cancer or a...
Yeah, so that's a really good question. So if a woman was going to go through the process of preserving her eggs, it's about the same cost as it would be if you had, a cancer diagnosis. And I would say about $5,000 of that is the cost of the drugs to stimulate the ovaries. And then it's about $3,000 more for the cost of the monitoring and the retrieval and the freezing part of the process. So it's a pretty similar cost to what it would be for a cancer diagnosis.
Okay.
And more women are doing this. Like actually Google and Facebook now pay if employees want to do this. We don't, that's not very common, but more and more women are choosing to do that just because they'll be 35 years old and they aren't in a situation to have children yet, or they aren't ready, or they're not in that situation, and they want this like as a backup plan.
It's great. It's a great option. I'm glad that the technology is there. I have another question. Does Gator Care coverage provide coverage for all reasons or only for cancer patients?
So right now, Gator Care covers some infertility services. It does not necessarily cover IVF or egg freezing for non-cancer reasons, but I hear that this may be changing very soon. They do cover it right now for cancer reasons. And you know, that's a pretty small number of people. So I suspect that they started off in that small arena and that's worked out pretty well. So, I mean, it's possible that's going to be coming very soon for other non-cancer reasons. But right now they do cover drugs and some diagnostic testing for infertility. So part of it can be covered, but I think that may be expanding, I think, in the near future.
Okay. Another question that came in is, if a person had chemotherapy, but didn't, you know, when it happened, didn't have anything to preserve their fertility, is there a way to see if the chemotherapy damaged the sperm or the eggs?
Yeah, so that's a really good question. So absolutely. So for males, it's quite easy. They could come in and give a sperm sample and actually just get a semen analysis. And we do those at Spring Hill. I mean, probably like, I don't know, 10 a day for infertility, but we can do it for any reason. So
Okay.
that'd be easy for a male to do that. For a woman, you know, normal periods are not necessarily a guarantee that fertility has not been affected, but that's a pretty good like biomarker that's overt. But there actually is blood work we can do on a female, usually on the second, third, or fourth day while they're bleeding. And that blood work can give an idea of their fertility at their age compared to other people. And you can tell if it's normal, low, or, you know, really low or absent. So there is, you know, some ways. For men, it's quite straightforward. For women, it's hormone blood testing that can give you some idea. That's a great question.
Okay. And then we had another question that came in. How do I start a conversation with my teenager who might be undergoing this? How do you start a conversation with someone who can't even imagine themselves being a parent right now?
So look, that's a really good question. So as a parent, so this is what I think. I think that a parent may not have to bring it up. In the ideal world, what's going to happen is, let's say you have I don't know, a 15-year-old boy who is diagnosed with an osteosarcoma. So this is a real case, okay? So they go to see their oncologist, and the oncologist says to the family, you're going to be getting this treatment. One of the potential side effects is that it might, you know, cause you to not be able to have children in the future. And really the conversation starts there. What do you think about this? And so probably that 15-year-old never even thought about it until, you know, they came to see the doctor and the doctor brought it up. But then I think what you would do as a family is go home and then you would sit down and say, you know, I know they brought up this really difficult topic. I doubt you even thought about it, but what they said is that, you know, this treatment could make you not be able to have a family. How do you feel about that? And would you want to try to do something about it? So I actually think at UF Health, at least, we have an AYA, which is an adolescent and young adult cancer program. And so there's actually a pretty standardized template for what they go through with each young patient. And in that template is fertility. So I think fortunately, at least I know for our program, and I would say like if you go to Moffitt or other places that have a big, you know, young cancer program, this will be part of the counseling when you see the doctors, and then that's a conversation you can continue at home. A lot of times though, when we see them, I mean, you know, they walk in the room, they like, what am I doing here even? I go, well, you know, you're here to talk about whether you want to do something to, you know, preserve your sperm and eggs. Have you ever heard of a sperm or egg? And then we go through the whole thing. So is that make sense?
Yeah, that does. Yeah, that's got to be an interesting
it is
conversation to have, and you know, you've got a lot of things on your plate when you're dealing with that. So that's really a fascinating side of things. I never even would have considered that you on your side are having to even explain what all this means. And this, you know, young person is wondering what's happening, where am I, and things.
Look, and I even, you know, sometimes I even say, look, I mean, I had little kids too. I'm not sure how I would have had that conversation with them, but here we are today and we have to talk about it. I draw a lot of pictures. We talk about the birds and the bees, and, you know, try to make it a real conversation that someone younger can relate to.
And what are some of the younger, I mean, what are some of the younger ages of children that you get sometimes?
I mean, so honestly, so far we have not seen anyone under probably 10.
Okay.
And, you know, the 10-year-olds that we've seen are pre-pubertal males. And so they are unable to produce a sperm sample. So if those families felt very strongly that they wanted to do something, which I think one of them did, they actually could fly off to another program that has a research protocol for freezing tissue. We have a fertility urologist coming to join our group in July. And so we're planning to start those IRBs here. So we could offer that to young males or young females here. Okay.
Well, I don't have any. Oh, I do have one more question just came in. Does someone need a referral to see you or to get this process started, or how do they get started?
So you really don't. You can call yourself and just say you want to come and see one of the reproductive endocrinologists. There's 3 of us total. There's 2 males and 1 female. We all work out of the same clinic as a team. And so you would just call that phone number and, you know, make an appointment. You can refer yourself to see one of us. You can always do that.
All right. Well, I thank you so much for your time today. I don't have any more questions that are sitting out there to ask. It's been a great conversation and I learned a lot. So thank you.
Okay. Well, thank you very much, Marcia.
Okay.
We'll see you soon. Okay. Bye-bye.
Bye.